So on that note, about when to doubt a secondary headache and about the epidemiology of primary and secondary headaches, we'll discuss about migraine, which is one of the most important primary headache disorders. And statistically, it is the second most common primary headache disorder. The most common is tension type headache. The most common is tension type headache. All right. So migraine is responsible for a quite significant neurological morbidity as well as disability. Lot of leaves, lot of loss of work days because of migraine headaches. It's more common in female patients. And when do you suspect that yes, this primary headache is a migraine or this is not a migraine? Is whenever there are associated symptoms and features. So what do you mean by that? So it's not only a headache. When you have associated symptoms and features, that time you suspect a migraine. So what are these associative symptoms and features? Aura, either visual aura, neurological aura, nausea, vomiting, phonophobia, photophobia. So these are all associated symptoms. And next is migraineurs in general are very sensitive to sensory or environmental stimuli. So what are the different phases of a migraine headache? There are four phases of a migraine. So we'll go into that. Next is the aura. First is the aura phase. So remember that around 20 to 25% of patients will have an aura. This can either be a visual aura or it can be a neurological aura. So visual aura can usually take the form of flashing lights, zigzag lines, and sometimes it can even cause monoocular vision loss. Can even cause monoocular painless vision loss. So you might even think it is actually a retinal ischemia, but actually it is a type of migraine which is known as retinal migraine. The aura phase is actually preceded by the aura phase is basically a headache which is preceded by a monocular painless vision loss. Next is neurological aura. So neurological aura could take the form of a sensory disturbance. It could be the form of a weakness. Could be a language dysfunction, or it could be a brainstem dysfunction, which is the erstwhile, which is the migraine with brainstem aura, or basilar migraine, the erstwhile basilar migraine, migraine with brainstem aura. Or it could be a part of, or it could present as an ophthalmoplegia, very commonly the third cranial nerve. So this is actually known as ophthalmoplegic mind. This is known as ophthalmoplegic mind, right? So sometimes, even way before the aura phase, you could have something which is known as a prodromal phase or a premonitory phase. So this actually precedes the migraine by around a few hours to days. Patient can have yawning, tiredness, something like a brain fog, and their mind isn't really functioning that well. That's a cognitive dysfunction. They could have mood changes, neck discomfort, polyuria, and food cravings. So first you have the prodromal phase, plus or minus then an aura phase, after which you have the headache phase. So the headache phase usually lasts for around 4 to 72 hours. When it lasts for more than 72 hours, it is known as status migrainosus. So this is an important MCQ question, especially for any SS. Whenever a migraine lasts for more than 72 hours, that is known as status migrainosus. Other features of a migraine headache is that it is throbbing or pulsatile in nature, can be both unilateral or bilateral. Usually we assume that migraine is hemicranial or it's always unilateral. That's not the case. Many at a times it can actually be holocranial. But whenever you have a side locked headache, whenever you have a side locked headache, when the headache is always only present on one side, that time you'll have to think whether you're dealing with a secondary headache. Okay, when it's always fixed to one side, then you have to work up for a secondary headache. Next, they're going to have nausea and vomiting. They can have photophobia, and cutaneous allodynia. You touch the face, they feel very painful. Then after the headache phase, there's going to be a post-drome phase, which lasts around an hour up to a day after the headache. The patient is feeling very tired and they have problems with concentrating and they have neck discomfort. So this is a table from the latest Harrison, which has summarized the different phases of migraine. So the first phase is the premonitory or the prodromal phase, where you have a neck discomfort, brain fog, mood issues, some fatigue, some yawning, polyuria, food cravings, increased thirst, after which you may have an aura phase in around 20 to 25% of patients. This is usually a visual aura or a neurological aura, can be in the form of a scintillating scotoma, or it could be neurological disturbance like a weakness or a sensory disturbance. It could be a language disturbance, or sometimes it can even be brainstem dysfunction or ophthalmoplegia. Next, third, we have the headache phase, where you're going to have pain with nausea, vomiting, pulsatile headache, photophobia, osmophobia, allodynia, cutaneous allodynia, and vertigo. Sometimes the vertigo can be, sorry, sometimes the vertigo can be quite severe, and you have actually a subtype of migraine that is known as vertiginous migraine. And then the last phase is the post-stroke, where the patient is quite tired, weak, and has impaired concentration. So that's about the different phases of migraine. So I did mention earlier that migraineurs are very, very sensitive to environmental stimuli or any changes in the environment. So that is why the important question that you have to ask a migraine patient in the history is identifying triggers. It's like why you want to know the triggers? What does it matter? Because you could literally completely treat a patient if you're able to identify the triggers and make sure that they consciously avoid it. It's very easily identified by making note of a headache diary. So let's have a look at what are the important migraine triggers. So it could be the form of bright lights that can trigger it. It could be loud sounds, hunger. So skipping meals is very, very important. Very common you see the patient they skip the breakfast and they get a very bad migraine. Very commonly skipping breakfast or any other meals for that fact. Next is let down from stress. So note that not only stress, but even let down from stress can trigger a migraine. What is this let down from stress? So you have a very busy day, like you had a night duty at 24-hour admission day, and then finally it's a long 36-hour shift, and you come back home, then you just relax, switch on the TV, watch your favorite show. That let down from stress can actually be a trigger for migraine. Interesting. Next is physical exertion. Sometimes even weather changes, hormonal fluctuations during menses. So sometimes you can have an exclusive migraine that occurs only during the menses. This is known as menstrual migraine. Next, lack or excess of sleep. Very, very important. Alcohol. So identifying patients' individual triggers, making sure that they consciously avoid it is a very, very important part of treatment of patients with migraine. So, regarding the pathogenesis of migraine, what are the important neuroanatomical structures that are involved in this? So, the trigeminal nucleus, okay, that's very, very important part. The trigeminal-vascular system is very important for the pathogenesis of migraine. Next is the locus ceruleus in the pons, the rostroventromedial nucleus in the medulla, the ventrobasal and posterior nuclei of the thalamus, the periaqueductal gray, and the hypothalamus per se. So what are the important neurotransmitters that are involved for migraine? That are involved in migraine. This is important understanding this because most of our medications that we use as either acute or prophylactic agents act on these neurotransmitters. So your most important one is your 5-hydroxytryptamine, that is serotonin. So important molecules that act on this particular receptor are your triptans as well as your ditans. Next, you have dopamine. So very common we use dopamine uh, dopamine agonists like domperidone or dopamine antagonists like domperidone or metoclopramide in the acute treatment of migraine. Next, a very, very important molecule that is calcitonin gene-related peptide. Lot of new drugs and upcoming studies to say that these drugs are useful not only in migraine, there's even reconnaissance of data to say that it's even useful for cluster headaches, that is trigeminal autonomic cephalgias. So your CGRP receptor antagonists are your gepants, and then you have around 4 monoclonal antibodies. We'll discuss all about this. So you have monoclonal antibodies that act either to the receptor or to the peptide of the CGRP. And another recent molecule that is which is undergoing research, is the PACAP, that is a pituitary adenylyl cyclase activated polypeptide. So, what is the diagnostic criteria for migraine? So, number one, the patient should have repeated attacks of headache lasting for around 4 to 72 hours in patients with a normal physical exam and no other reasonable cause for the headache. And the patient should have at least two of the following features. What are these features? Unilateral pain, throbbing pain, aggravation by movement, moderate or severe intensity, plus at least one of the following features, that is nausea and vomiting, and photophobia and photophobia. So very, very simple diagnostic criteria for the management of, for the diagnosis of migraine headaches. So that's about the pathogenesis and diagnostic criteria. Now we'll come into the management of a patient of migraine. So I would say that one of the most important parts of the management of migraine is the non-pharmacological part. So number one is you have to ask the patients to maintain a headache diary. It's very, very important. So number one, it helps the patient keep a conscious tab about how the headache is. It can help them identify their triggers. It can also see whether the medications that we're giving are helping or not. So please make sure that all of your patients maintain a headache diary so that you can assess the trend of the headache or during your consults, during your OPD consults. So number one, most important thing that I've already emphasized so many times is that you need to identify and avoid the migraine triggers. Healthy diet and regular exercise, proper sleep hygiene, avoiding excess caffeine and alcohol. So even though that caffeine is actually used as a treatment option for migraine, patients who get habituated to caffeine, at any circumstance, if they miss the dosing of caffeine that particular day, that itself could act as a trigger for a migraine attack. So that's about the non-pharmacological management. How do you treat migraine? So we'll discuss the treatment of migraine as acute management of migraine as well as the prophylactic management of migraine. So the most important treatment is your non-steroidal anti-inflammatory drugs. So you make sure that these are started early. They're useful for around mild to moderate intensity of attacks. Commonly used medications are naproxen, ibuprofen, and diclofenac. Adding dopamine antagonists help. Okay, so usually a very commonly used combination is domperidone 10 mg. So I use this very, very often. So I add it either along with paracetamol 650 milligrams. So I use this for mild headaches. It's a little bit more moderate. I usually prescribe domperidone along with 500 milligrams of naproxen. Okay, so adding domperidone really helps. It's not just because migraine is associated with vomiting. Remember that in migraine, the oral absorption of drugs is actually impaired. So adding domperidone to your NSAID is definitely going to help. And very, very important, start it early. Start it early. So I'm a migrainer myself. So I usually always carry my domperidone and paracetamol medications along with me. So whenever I get it, I know I'm going to get a bad attack. Usually I take it within 30 minutes of the headache onset. So the bottom line is adding a dopamine antagonist along with an NSAID definitely helps to reduce the headache. I personally don't prefer metoclopramide because it has I've really burnt my fingers many times in the sense that it can cause a drug-induced attended the class on movement disorders. So it can actually cause the acute dystonia. Okay, so many times we've seen metoclopramide that can cause an acute dystonia. So I'm not a really big fan of that medication. Next, regarding triptans. So triptans act on the serotonergic pathway in sense that they are 5-HT1B bar 1D receptor agonists. And they act on both the neural targets as well as the vascular targets. And non-selective 5-HT1 agonists are going to be your ergot alkaloids. Ergot alkaloids. So ergot alkaloids like ergotamine or dihydroergotamine have been used, but usually because of their safety profile, triptans are more prescribed more often. So rizatriptan and elatriptan are the most effective triptans. Sumatriptan and zolmitriptan are present in multiple formulations. Yeah, sumatriptan is present as a subcutaneous injection. It's present as an oral tablet. It's also present as a nasal spray. And similarly, zolmitriptan is present both as an oral tablet as well as a nasal spray. Next is provatriptan and naratriptan are generally well tolerated. And but the problem is usually triptans might, even though it is effective initially, the major issue with triptans is it causes headache recurrence. So that's why it's not very useful as a monotherapy. So usually we combine a triptan along with a non-steroidal anti-inflammatory drug. This is a usual comment because when you start sumatriptan, the patient gets better, but after that, later 1 hour or 2 hours later, they get a headache recurrence. So to prevent this, usually we combine it along with another medication, most often an NSA. And remember that triptans aren't very useful during the aura phase, and it's contraindicated in patients with cardiovascular, cerebrovascular, or peripheral vascular disease. So this is a tabular column from the latest Harrison, which has summarized the different molecules that are used in the acute management of headache. So we have a combination of acetaminophen, aspirin, and caffeine. Then we have your NSAIDs like naproxen, ibuprofen, diclofenac, tolfenamic acid. And after that, we have your triptans, which are your 5-HT1B1D receptor agonist. So don't forget to remember the receptor name. And it's very commonly asked MCQ. They'll ask you whether it's an agonist or an antagonist. In the exam, we very often get confused. So remember that triptans are 5-HT1B bar 1D receptor agonists. So common molecules over here are your ergot alkaloids, which is actually non-specific. Specific ones are going to be your triptans like naratriptan, rizatriptan, sumatriptan, provatriptan, almotriptan, elitriptan, and zolmitriptan. And then remember that you also have certain nasal formulations of your 5-HT1 molecules. You have dihydroergotamine present as a nasal spray. You have sumatriptan and zolmitriptan, which is also present as a nasal spray. And parenteral, we have sumatriptan that is present, that is used as a subcutaneous injection. Remember that subcutaneous sumatriptan is also used for it's also useful for acute attacks of cluster headache. Then you have dihydroergotamine, which is present as IV, intramuscular, or subcutaneous injections. Next, you have your CGRP receptor antagonist, that is your gepants. So there are two important oral drugs in this group, that is remigepant as well as ubrogepant, and a very new addition to this group of molecules, that is zavegepant, which is actually a nasal formulation. Okay, so this could be a future MCQ because it is the latest update. So remember that the gepant, which is given in the intranasal route, is zavegepant. Intranasal triptans are zolmitriptan and sumatriptan. Next, you have your diltans, which is 5-HT1F receptor agonist. One molecule in this, the one and only molecule in this group is your lasmidite. So remember that your diltans, so you know your triptans aren't very safe with regards to cardiovascular, cerebrovascular disease. So your diltans are supposedly cardiac safe. They're supposedly cardiac safe. Next, you have your dopamine receptor antagonists. So we have oral medications like metoclopramide and prochlorperazine. Parenteral ones are your chlorpromazine, metoclopramide, and prochlorperazine. And other things are your neuromodulating agents. So we have transmagnetic stimulation, non-invasive vagal nerve stimulation, remote electrical neuromodulation, transcutaneous supraorbital nerve stimulation, and very recently your ECOT-NS, that is external concurrent occipital and trigeminal neurostimulation. So very commonly used devices over here. You have your Gamma Core device, which is a non-invasive PNS device. You have your Nerivio, which is actually present in the market. This is a remote electrical neurostimulation, basically gives stimulation to the upper arm. Then you have the Cephali device, which is placed in the head, which is used for transcutaneous supraorbital nerve stimulation. So these are the neuromodulating devices. Just put a few for representation. So this over here is the Gamma Core device. This is the Gamma Core device. Over here, this is the Nerivio device. Okay, this is actually present in the market currently. And you also have the Cephali device, which is basically supraorbital nerve stimulation. Transcutaneous supraorbital nerve stimulation. So that's about the acute management of migraine. Now we'll come into the prophylactic management of migraine. So these are the list of the FDA approved medications for a prophylaxis of migraine. So your beta blockers like propranolol and tremolol, your gepants like rimigepant and atogepant. Then we have sodium valproate, topiramate, and then your monoclonal antibodies to the CGRP molecule, that is eptinezumab, fremanezumab, calcanezumab, and erinumab. So these are the important prophylactic medications. As I mentioned, your beta blockers, then your tricyclic antidepressants like amitriptyline, dosulpin, nortriptyline, and venlafaxine. Then you have your anticonvulsants like topiramate as well as valproate. Then we have serotonergic medications like pizotifen, not very commonly used now because of its mainly because it's associated with weight gain. And next is your CGRP pathway blockers. That is your eptinezumab, erinumab, fremanezumab, and calcanezumab. And your gepants like rimigepant and atogepant. Other medications is flunarizine, very, very commonly used. It's a calcium channel blocker. Then you have candesartan, memantine, and melatonin. Neuromodulation, very, very important. It's not only used for the acute attack of migraine, it's also used for your prophylactic management. So your transcranial magnetic stimulation, your non-invasive vagal nerve stimulation, remote electrical neuromodulation, and cephalic device, that is your transcutaneous supraorbital stimulation. Then very, very important. So we all spoke about acute migraine. For chronic migraine, that is patients who have more than 15 headache days per month for at least a period of 3 months, of which 8 or more are of migraine quality, these are defined as chronic migraine. The only approved drug for chronic migraine is botulinum toxin. That is ONA botulinum toxin type A, 155 units, 155 units. And remember that it is the only approved drug for chronic migraine.